My name is Lindsay, and today we're going to talk about revitalizing culture and healing, catalyzing action on FASD prevention. Before we begin, I would like to acknowledge that we're coming together from diverse ancestral, traditional, and unceded territories across Turtle Island. And I want to acknowledge First Nations, Inuit, and Métis as the first inhabitants and traditional custodians of the land in which I live, learn, and play, and particularly recognize that I am presenting from the traditional territory of the Haudenosaunee, Anishinaabe, Mississaugas, the Credit First Nation, Mississauga, and Wendake Mi'kmaq. I pay my respects to elders past, present, and emerging from across Turtle Island. I also want to start with a moment of silence. Yesterday was a heavy day for many, as have the days before and the days to come. And I really just want us to sit for 30 seconds of silence. Thank you so much. So as Anna mentioned, I worked in collaboration with so many people in this efforts and on the booklet. I want to acknowledge both the staff at the Center of Excellence for Women's Health, as well as the Indigenous and non-Indigenous women. I don't typically present this without one of the many amazing collaborators that's on the screen. And so you'll notice that when it comes to talking about the resource itself, I will not be speaking to any of the programs specifically, as the booklet was written in the words of the women service providers. And I think their voice and their story is so crucial and so important. And so that will be central to what I talk about today. So as Anna mentioned, my name is Lindsay. A little bit about myself beyond the formal introduction is that I'm a settler. My family came as settlers and refugees from Poland and Russia. And I've been working in FASD prevention for about 5 years. Before that, I worked in anti-violence and anti-human trafficking efforts, particularly around policy and advocacy. And so much of the work that I see and that I do has these really pivotal interconnections, and central to both is a need for destigmatizing and trauma-informed approaches. Today, in talking about revitalizing culture and healing, we'll be doing a number of things. We'll be walking through a number of foundational components. So that includes the foundation of FASD prevention and expanding on areas of prevention, including brief interventions and community-based driven FASD programs. We'll also be talking about stigma and its important conversations and what it means for healing and wellness programming. And at the end of the presentation, we'll go through a Q&A period. So when we're talking about FASD prevention, and I'm sure it's been clear throughout the conference, we're not just talking about one level. We're not just talking about posters and information, but we're talking about this sort of integrated system that includes information about the risks of alcohol use in pregnancy, discussions around alcohol use in pregnancy, having specialized holistic support for pregnant people and new mothers, and then intertwined with all of this is supportive alcohol policy and child welfare policy. And really, if these systems all work together, if all of these levels work together and intertwined, it's intended to improve the health of pregnant people, of their children, of their communities, and their extended family and support networks. So level 1 prevention, what we're talking about here, it's broad awareness building and health promotion efforts. So we'll see things like pamphlets and education materials, low risk drinking guidelines, materials for facilitators for girls or women's groups. We'll see warning labels included in this level and community-wide health promotion strategies. So some of these images may be familiar to you. At the bottom left, we have the This Is Why campaign from the Saskatchewan Prevention Institute. Up at the top, on top left, we have this great poster that says, "Friends help friends, choose a healthy lifestyle. Please do not drink alcohol during pregnancy." And that was from the BC Aboriginal Network on Disability Society. We have this poster on the right that says, "Alcohol and pregnancy don't mix. Healthy mothers and babies need everyone's support." And on the bottom right, we have this poster from the Yukon that says, "Let's meet at the coffee bar." And I think what's really special about this level of prevention is you're doing this broad awareness campaign, but it's also so important to tailor to the population. So I know that a conversation, particularly around this poster for the Yukon, was if it could be used in Nunavut. And when that was a conversation at the time, there was not a cafe in Iqaluit, so they couldn't actually use this poster. And so tailoring it to our contexts can be a really powerful strategy of doing FASD prevention. This second level I'll be going into in a bit more detail, and it's really about discussing alcohol with girls, women in their support networks. And often when we're referring to these, we're referring to these discussions as brief interventions, and they're really intended to build trust and a relationship between individuals and providers. And they're great opportunities to ask questions and learn more around alcohol and other substances, as well as contraception, safe sex, and other related health concerns. And so as we go through the presentation, I'll talk about the many ways that these conversations can be had, but also the ways in which these conversations can be made wellness oriented and embed culture within. So that way we are focusing on the whole person rather than solely focusing on physical health. In this third level of prevention, we're thinking about specialized holistic support for pregnant people with alcohol and other health concerns. And this can look so many different ways. It can include outreach, practical support. Often these programs are harm reduction oriented, so they may not have an abstinence focus, but focus on how to reduce harms for pregnant people. Often they include integrated support. They focus on pregnant people as a dyad with their children, and they're trauma informed. And so here are two examples of programs. On the right hand side, we have the Mothering Project, Manitou Ikwe Kikikwe, which is in Winnipeg. And this is a photo from their absolutely beautiful smudge room. And the program really does offer so many different things for pregnant people and new mothers who are using substances. It's co-located within a health service, but it also has nutrition embedded. And you see this beautiful smudge room, and there's gardening, and there's a daycare within the facility, and women are connected to health services within the facility. And so you can see how this really wraps around pregnant people as they may be seeking support, or folks who are postpartum and their children. And Shiway is located in Vancouver and offers a lot of the same programming. And similarly, they are located within a housing unit. And so folks who are accessing program might be part of or may live within the housing facility, and they are also able to access nutrition services and nurses and elder support, and just a variety of programs that really respond to women as a whole. And this fourth level is really similar to level 3, but rather than focusing on pregnancy, we're looking at postpartum interventions and support. So this may look like home visitation postpartum by nurses. It could look like the parent-child assistance program or other peer mentorship programs. And so this is the PCAP program, as I'll refer to it, is a peer mentorship program where advocates and mentors work with women who have had children for up to 3 years. And that can look different depending on what community is offering the program. And it may also look like substance use treatments. So in Toronto, for instance, the Jean Tweed Center offers Moms and Kids Too, which is a day treatment program which allows moms to bring their kids and live at home with their families. And I really think that, we'll talk about this a little bit today, but I think that tomorrow's presentation on integrated and wraparound care will also speak to this level of support. So I want to spend the next little bit talking about what it means to expand on brief interventions. So as you can see, we have this little arrow. We're going to be focusing on level 2, and I think that this is a really important level because we are able, you could see in level 1 how culture can be integrated within different posters through language, through imagery, through responding to geography and community needs. But in level 2, we get to a more personal dialogue. It's not a population level approach. We're thinking about individuals and their support networks directly. And so these are really conversations that we have the opportunity to reduce stigma, but also integrate culture within these conversations. And so when we're talking about brief interventions, we are talking about these conversations that support people in learning more about the health issues that affect them. That may help people reflect on health promotion strategies. These conversations can support people in making any needed changes in their health and substance use. Support people in making connections between substance use and sexual health, mental health and wellness, and other determinants of health that might facilitate plans for change, and support people to identify and strategize how they can address underlying concerns that may be directly or indirectly related to substance use. And that could be depression, intimate partner violence, a lack of resource and knowledge around alcohol use and pregnancy. And these conversations can happen in a myriad of ways. They can be formal or informal, they can be structured or unstructured, and they can happen one time or over a series of time. And I think the flexibility in brief interventions is so important because, particularly when we're talking about what it looks like to engage in a brief intervention with Indigenous peoples, oftentimes these are not brief conversations. That language in itself is not appropriate. And so maybe we're looking at it as a doorway to conversation. The context of brief interventions often is situated within screening, brief intervention, and referral. And so it's seen as sort of like this centerpiece. But personally, that may not be the most appropriate way of placing it. And that's because screening may not fit into existing practice approaches. And it can also really focus on a behavior in a way that's seen as judgmental or stigmatizing. But by engaging in brief interventions, we're really thinking about having these conversations that are relational, that are rooted in building trust, and that are trauma informed. And there are so many different ways that we can engage in these conversations, regardless of what our role may be. And so brief interventions certainly can be taken on by nurses, by midwives, by folks who are working in sexual health clinics, anti-violence workers, folks who are working in substance use treatment. And there are all these different ways that we can think about building these connections. And so on the right-hand side, you can see this checklist. And this was part of a booklet that we created a few years ago called Doorways to Conversation, in which we were looking at what those connections may be. And so perhaps to somebody's practice, talking about alcohol use wouldn't be the entry point, but by thinking about parenting or breastfeeding, there might be a conversation. Similarly, by talking about mental wellness and wellness as a whole, perhaps it's an entryway to talk about alcohol or related health issues to alcohol use. And there are so many different ways that we can think about it. There are so many different values that are embedded within brief interventions. And so this is, a list of 10 of them that we've identified that we're really thinking about meeting clients where they're at, and having individuals identify their own goals and solutions. We're also talking about being trauma informed, so physical, emotional, and cultural safety, offering choice and collaboration. And that might mean that within your brief intervention, you're recognizing that substance use might be used as a means of coping. And so there might be a conversation of what alternative ways to cope might look like. And we also see these last three principles on the right-hand side, a focus of cultural safety, on Indigenous wellness, and on social determinants of health, and really recognizing the role that alcohol use, or that colonization, has played in alcohol and other substance use, and finding ways of supporting Indigenous ways of knowing. And that could look like holistic approaches. I know that brief interventions, as I'll get to, have looked a variety of different ways. And so perhaps they are part of land-based programming, perhaps they're done on walks, and they're a nod to a conversation instead of a conversation that's had within a medical office, where there isn't the safety that is needed in order to build trust and a relationship. What we see from the research is that brief interventions, or on multiple substances or on multiple health concerns, can be really supportive. And so we can see this image from Project Choices, which is in Manitoba, where there's a focus on alcohol use and contraceptive use. And even by prompting the conversation around alcohol and contraceptive use, we can see that there is an increase in contraceptive use. And, there's a slight increase in alcohol use, but the way that a lot of folks have addressed prenatal alcohol exposure and unplanned pregnancy is by increasing their contraceptive, increasing their condom use, increasing their birth control use, looking at different forms of birth control. And on the right, we see this handout, and this is from work we did with the Girls Action Foundation, but really looking at all of these different interconnections that girls may have with substance use. So mental wellness, safety, weight. And again, by looking at these different entry points, we're more likely to have effective and engaging conversations rather than dressing alcohol or other substance use as a one-off. Brief interventions are also a part of motivational interviewing, and some of the folks on the line today may have received motivational interviewing training before, but really, again, they're supporting what women already know about risks of various substances in their life. They also normalize conversations. And so, one thing we always say is that if you ask everyone as part of your practice, it becomes just a normal conversation folks have, rather than this very weighted, very stigmatized conversation, when that certainly does not need to be does not need to be the case. And it's also, brief interventions can also be this pathway to healing, to treatment, and to cultural learning. And so there have been so many ways in which brief interventions have been adapted. So we have seen that in the US, Project Choices, which, as I mentioned, is this dual intervention looking at alcohol and contraception use. We have seen that resources have been changed so that way, instead of 4 face-to-face motivational interviewing sessions that were one-on-one, they'd be group interventions. They would use cultural appropriate imagery, integrate local data, improve the readability of materials. And there are other ways that we can do it. In other parts of Turtle Island, We've also seen that brief intervention has been part of blanket exercises or land-based programming. I know that in one of the communities that I work with in Labrador, they do a long walk, and it's a girls' walk. There are also women's and men's and community walks, but as part of the girls' walk, the FASD facilitator will just talk about alcohol as part of the walk, and perhaps it will be part of building a fire, that you're talking about healthy relationships. And these are these very meaningful ways of having brief interventions and also making them culturally appropriate, or building in referrals to Indigenous specific programming where that is not a possibility. And this can be a far less stigmatizing and a far more respectful way to discuss substance use, because it is looking from a strengths-based perspective. We are embedding, we are reframing these conversations and framing these conversations in general so that way they are wellness oriented. And so, as I mentioned, in the adaptation of project choices, which in non-Indigenous populations looked like 4 face-to-face motivational interviewing sessions, these one-on-one conversations, a community assessment revealed that some changes needed to be made. And part of that included group programming. And so in other places, such as in Australia, we'll see similar programming may be offered during bingo nights, or one of the communities that I work with in Western Australia does like pedicure nights, and they'll just talk about alcohol within it. And it's really, again, a way of like normalizing the conversation, but it also changes power dynamics. And so it's within the community rather than it being like one-on-one between a provider and an individual. And again, as I mentioned in this adaptation, there was an inclusion of culturally appropriate images, integrating local data, and it was really effective in reducing self-reported alcohol use, but and also in increasing effective contraceptive use. This is a handout that we use, and I think this could be adapted in so many different ways, but it can really be used to bust myths and respond to challenging statements. And so using handouts and other materials as a guide can be really helpful in reflecting on like, what might you continue to do, what might you avoid, and what might you change in your approach. And so this can be a consideration in brief interventions, but also in what adapting brief interventions, that way they are safe to folks who you are having these conversations with is done. And I think that's the case for like all visual resources. I think they can be so helpful in enhancing efficacy. They can also be really helpful in building confidence. And one of the resources, Knowing Your Limits with Alcohol, before that's what it was this handout here, created by Pathways Institute. And I realize only now that I'm holding the French copy in my hand, but included in it, do we see like low risk drinking guidelines, so folks can reflect on how much alcohol they may be drinking, why alcohol is an important component of their life, what are things that people like about alcohol use, and what are things that people dislike. And so identifying, is alcohol being used as a coping strategy? That's something that a booklet like this can do. But in addition to the booklet, Pathways Institute, they also created cards. And so all of the cards were then adapted. They were working with 3 communities in northern Manitoba, and all of the images were adapted so that way they could be appropriate to the community. And so there are really intentional ways that we can make brief interventions in themselves community and culture led and community specific in how we're doing the work. And so I'm going to move us forward to thinking about how we can expand are community-based and community-driven FASD prevention programs. And this is really where I'll start to talk about our resource Revitalizing Culture and Healing. And I think that you'll hear similar things, or you'll hear about some of the integrated programs tomorrow morning in one of the early presentations. So we're going to move down to this level 3 and level 4, where we're thinking about specialized holistic support. And these are some of the building blocks that really have taken us to what we're now calling Revitalizing Culture and Healing, that brought us to co-developing this booklet. And the first is on the left. It's called It Takes a Community, for those that have not seen it before. And it was published in 1997 by the Public Health Agency of Canada, but was written by a nurse from Selkirk First Nation, Marilyn Van Bibber, and it included a holistic framework for understanding the complex root causes of substance use and the potential for community action. And it really embodied Indigenous values within it. It recognized the importance of self-determination in developing community-led strategies unique to individual communities, and linked traditional values and holistic health frameworks with the latest knowledge on FASD. This framework still to this day is the only resource on FASD prevention that has been released by any provincial or federal government that speaks to the importance of community and culture-led approaches. Since It Takes a Community was published, we've also seen a release of the full report of the Truth and Reconciliation Commission of Canada, their full report, and the 94 calls to action, which again highlight the importance of collaborative community-driven responses. And there were 2 calls to action on FASD. The call to action 33, which was on FASD prevention, which I've highlighted here. The need for to address and prevent FASD and develop in collaboration with Indigenous people, FASD preventive programs that can be delivered in a culturally appropriate manner. And there was also call to action 34, which is around FASD and justice. And the TRC calls to action were so important for so many different reasons that I don't think need to be said in this audience. But call to action 33 in particular was a driver of new and renewed action on FASD prevention in Indigenous communities, and really prompted the ability to collaborate on thinking through what prevention programs could look like that furthered community-driven actions, because so much was already being done. Another foundational component was thinking through cultures as intervention. And this is work by the Thunderbird Partnership Foundation, which was at the time known as the National Native Addiction Partnership Foundation. And so we have the First Nations Wellness Continuum on the left, and then on the right, we have the Indigenous Wellness Framework. And this is a very big circle that we have on the left that encompasses so much. In the center, we have the medicine wheel with the 4 directions, focusing on the outcomes of hope, belonging, meaning, and purpose. Surrounding it, we have community, so kinship, clan, elders. We have populations and specific population needs on top of it. The continuum of essential services, including health promotion, prevention, community development, and education, early identification and intervention, crisis response, etc. Supporting elements, including performance measurement, governance, self-determination, our partners in implementation, the Indigenous determinants of health, and then the key themes for mental wellness and culture as foundation. So on that last layer of culture as foundation, we see elders, cultural practitioners, kinship relationships, language, practices, ceremonies, knowledge, land, and values. And all of these different circles were really foundational to thinking through what first was known as the consensus statement, but secondly, in developing this booklet on revitalizing culture and healing. And the last foundational element was two-eyed seeing. And so for those who have not heard of two-eyed seeing, it refers to the understanding of Indigenous and Western knowledges as distinct worldviews that are woven together. And that gives the ability to integrate strengths of Indigenous knowledge and Indigenous knowledge systems about health and wellness within Western science. And certainly when Marilyn Van Bibber wrote It Takes a Community, she was using a similar approach, despite not naming it as such as at the time. And so getting us to where we are today, what is revitalizing culture and healing? It took a long time, and it could not have been done without these fundamental resources, like having the First Nations mental wellness continuum framework, without having It Takes a Community, and without taking Call to Action 33, which really did act as this driver to bring us all together. And so the first meeting that we had that helped determine this work was in 2017 on the unceded territory of the Coast Salish people. And it brought together experts from nations and different organizations that were working on Indigenous health and wellness and FASD prevention. And the purpose of this was really to inform what robust and culturally safer approaches to implementing Call to Action 33 on FASD prevention may look like, affirming the role of having cross-disciplinary and cross-organizational approaches, while affirming the priority to have Indigenous knowledge systems guiding the work, and then promote an ongoing and collaborative commitment to reconciliation. And the consensus statement really aligned with successful approaches to FASD prevention and wellness, and was used to create these supplementary booklets, but also started conversations about what programs could look like as they were being developed down the road. And so as a group of, I think there were 30 of us at the time, we identified these 8 principles. These principles that we saw as what it would look like to have like Indigenous principles for FASD prevention. And they included centering prevention around Indigenous knowledge and wellness, really recognizing the principles of land, lineage, and language as guided by the mental wellness continuum, and using the wellness framework so that way we were able to support individuals, families, and communities in achieving the balance that we saw within the medicine wheel. We also said that there was such importance in using a social and structural determinants of health lens, that if we do that, we could go beyond addressing individual behavior to positively support women's wellness and healing, and that also of families and communities. That we needed to highlight relationships, that FASD programs must acknowledge and support the role of extended family in child development and socialization, and that when elders, community members, knowledge keepers, and extended family members share their knowledge about pregnancy, childbirth, mothering, and talk about essential components of language and culture, that we're able to really preserve language and culture. And so building prevention programs that highlight relationships, further integrate culture into practice, and can develop respectful relationships between community members and with researchers and service providers. We also, and this is sort of the theme of today, or the theme of this talk, that programs must be community-based and community-driven. and that by doing so, we're able to respond to geography, infrastructure, language, culture, values, human resource capacity, etc., that really support engagement in services. And they can also go beyond responding to individual barriers to address structural barriers such as systemic and institutional racism that may result in women not feeling comfortable engaging in prenatal care or in being a part of a brief, being engaged in a brief intervention, for instance. And so by having community-led and community-driven services, we're able to dismantle these barriers. We also talked about the importance of having wraparound support and holistic services. And so that involves coordination across community supports and services to meet the complex emotional, mental, physical, and spiritual needs of women and families. And it recognizes the existing supports from community and extended family. And so that way we can tailor to mothers and children's needs and build on existing strengths. We said that it was crucial to adopt a life course approach, and that recognizes the historical and cultural role of pregnancy and childbirth as a sacred part of the life cycle, and that by recentering FASD prevention programs as really thinking across the life course, we were better able to recenter service delivery around Indigenous worldviews, promote positive parenting, and reinforce familial and community roles to raising children in ways that disrupt intergenerational trauma. Lastly, we talked about models that support resiliency for women, families, and communities. And so that includes strengths-based approaches that situate Indigenous culture as foundational to program planning and implementation. And these models avoid stigmatizing claims like that FASD is 100% preventable, but instead uses strength-based models to empower women in their role as mothers and foster maternal-child attachment. And lastly, and I'll talk about this a little when we get into the booklet itself, is the importance of long-term sustainable funding and research. That oftentimes communities are given funding as pilot programs, but not in a sustainable way. And so it's really hard to build out this work and ensure that it's ongoing. And I know that that's a challenge that so many face in developing and implementing FASD prevention programs at a community level. So after the consensus statement was released, we developed these 5 booklets, and then there was still more to do. And so in 2019, we came together with First Nations Health Authority to really think through what community-based, community-led FASD prevention programs do look like. So unlike the first workshop where we said, well, there are definitely aligning principles that can be adapted to each community, we now wanted to see what that actually looked like in practice and bring together the work. And part of it, and this is something that we've heard a lot, is that FASD programming and prevention programming often feels like it's being done in isolation. And the hope was to bring together program providers, that way they had connection. And so we were able to share what was being done on FASD prevention and wellness programming, identify opportunities for evaluation if that was something programs of interest, and that of course was like linked to funding. What could we do to evaluate these programs to really ensure that there could be long-term sustainable funding? Discuss what research would be helpful to support the advancement of programming, and then how we can continue to collaborate and respond. And so lots came out of those meetings, and you can see it here. So in this first graphic recording, this was from the first part of the day. And so really focusing on how important relationships are, that we must support the whole family, that aunties, sisters, elders, traditional knowledge was all foundational to existing programming. And as we continued through the day, we talked about more things. We talked about the pervasive role of stigma that you can see, and I love this, I think about this daily, and it's 2 years later, this yellow sun of culture. That culture is central to all of the work that has to be done. And that is what's so central to having a community-driven and led program. But I think where people got stuck was that we were talking, there was so much stigma, and that, as you can see above the stigma flag, different spaces felt safer than others. And so I think that as we walk through what it means to support healing and catalyze action, we have to think through stigma and discrimination. And we can see that stigma can be experienced in so many ways. It can be experienced by women who drank alcohol during pregnancy, and also by individuals with FASD and their families and their support networks. And so we have to work with all of these different systems and sectors to address it. For individuals with FASD, stigma may be a barrier insofar that health and social care providers may misdiagnose or fail to diagnose children with FASD. And there's also, we see the public and media perception of individuals with FASD that are not strengths-based, that are inaccurate. And this can be really concerning, because where we see, that public perception, that's often where folks are going to get their information. They're going to the media, they're going to social media even to get their news. And so this misinformation can lead to like viral stigma. And for women, stigma is one of the biggest barriers to accessing care and to practitioners providing care. And this can be particularly challenging for women who are pregnant and are not able to seek prenatal care because they don't feel safe to do it. And so we have to think through what trauma-informed and harm reduction-oriented services look like. Improving public perception and messaging and reducing stigma is therefore fundamental. Health and social service providers should be looking to evidence-based materials about FASD to help support their capacity for referral, and integrating information into different schooling programs would be incredibly helpful in supporting this, but also questioning our own stigma and biases. And so in the bottom left, I have this booklet here called Mothering and Opioids, but it would be appropriate to thinking about women in substance use in any capacity. And this was a toolkit really meant to address stigma. And so within it, there are reflexive tools. There are also scripts that can be used, and some language guides. And as we talk a lot more about this resource for revitalizing culture and healing, you can see that addressing stigma was one of the 4 things that came out. And of course, this is the moment that my PowerPoint has decided to freeze. 1 second. So, revitalizing culture and healing. The reason that we're here today, that has had so much backstory behind it. This was a workbook that we came together and built with workshop participants, and it really articulated the diverse approaches to FASD prevention taken by communities and reaffirmed the role of Indigenous wellness systems or knowledge systems and wellness in addressing alcohol use in pregnancy. There were so many program developers and staff that participated in the workshop itself, but in the booklet, we had 7 programs. So in BC, we had participation from Skidegate Health Centre, Commodity Friendship Society, Gitsan Health Society, and Stalo Service Agency. In Alberta, we had participation from Alexis Nakota Sioux and Lakeland Centre for FASD, and in New Brunswick from the New Brunswick Centre of Excellence for FASD. And I really encourage everyone to read the booklet. I can put a link into the chat after the presentation, but each of the program providers wrote how their programs adopt one or several of the tenets included in the consensus statement of being community-led, offering wraparound support, adopting a life course approach, etc. And I just think it's so powerful to read about what these programs are doing in the program providers' words. Some of the highlights of the programs were that they really demonstrated the breadth of what a community-based and culture-driven program could look like. Many of the programs don't call themselves FASD prevention programs. They call themselves wellness programming. And I think that then goes to our conversation around stigma again. If it is not, appropriate to call something, if there's so much stigma behind FASD that it's not accepted to call something an FASD prevention program, or if that's not seen as a strengths-based approach, then we need to respond. And so many of these programs identify as wellness programs. Many of these programs do include a range of services within them, and many were adapted from the parent-child assistance programming. So whereas the original program involved supporting women for a 3-year period throughout their pregnancy and up to 3 years of age for their last child, many of these programs extended beyond. And so they wouldn't have a time that women would quote unquote like graduate out of a program, or if they did, it was maybe 6 years. And that was really so that way relationships were central to the work that was being done. And all of the programs addressed all 4 of these quadrants. They built purpose, they gave hope, they were embedded within them as creating a sense of belonging and meaning, and that was pivotal to the work. Some of these programs serve multiple communities. So for instance, Stalo Service Agency supports 11 communities. And so whereas some of the other programs, it's just 1. And so every response, every FASD prevention program certainly is going to look differently. We could see that some of the key components were having nation-driven and led programming, a focus on relationship building, on goal building, in tailoring to the needs of community, and some of the services offered. And this is just an abridged list, but included doula support, nutrition, prenatal education, postpartum care, systems navigation, so how women can access all of these different services that might be a part of prenatal, postpartum, or their children's care. Home visitation programming, budgeting services, cultural programming, sweat and other healing practices, programming for men, so having programming that was not exclusive to women, but that still gave safety to women as needed. Language learning, which was a component of 3 of the 7 programs, offering ceremony as part of what an FASD prevention program could look like, and also doing a lot of staff training. And at the end of the booklet, after describing what these 7 programs look like, we really talked about different actions that could be taken to develop and expand FASD prevention wellness programs. And these were the 4 sections: using non-stigmatizing language, identifying existing community strengths and program, identifying potential funders, and connecting with those that have walked before us. And this is a quote from Candace Sutterfield at the Lakeland Center of FASD. that the Mothers to Be Mentorship Program has found that conversations around families and FASD prevention can further reduce stigma. And there are lots of different ways that we can, at the back of the booklet, just like in the Mothering and Opioids booklet, there is this little section on the language that we use or the beliefs that we hold. And so instead of using certain language, we can think about other language that would be more supportive to individuals with FASD and individuals who may not be able to, or who may have used alcohol in pregnancy. One of the recommendations was to identify existing community strengths in programming. And one way of doing that is through asset mapping. And this is a process of identifying strengths and resources of communities. It allows individuals to think about how to build upon what is already there in order to address community needs and improve health, and it promotes community involvement. Often what we hear, again, as I said, like FASD prevention program providers often feel that they are within this one silo, and they are the one person within their community doing programming, but we know the interconnections with nutrition. We know that folks may need access to prenatal care, that Jordan's principle might be a really important position within the community. And so by linking what's already being done, we're able to build this network of folks that are actually working on FASD prevention, even if they didn't think it was part of their role. And so these maps can look all different ways. I have one example here and two more here, but just in thinking through the linkages. So in thinking through, what a linkage to anti-violence services might look like, or to gyms and other recreational programs, other things that might be really helpful in coping. And so these are all components of FASD prevention. They're all components of wellness, but they haven't necessarily been identified. And so the role of asset mapping allows us to build these connections and allows us to talk about community strengths and build on strengths without adding a workload to anyone, but just focusing on collaboration and relationships. As I mentioned, funding has historically been a really challenging arena for many folks. And so all of the program providers that collaborated on this booklet really recognized the role of identifying potential funding partners and sort of hinted to how they've maybe creatively been able to access funding. And so where programs are hitting on these multiple needs, where they may include a community health nurse, or they may include a dietitian or nutritionist, or might involve an elder, how different streams of funding can be used to create this very whole program. And while the funding might feel a little bit piecemeal, it also creates a little bit more sustainability and also build programs that are completely responsive to community needs. And more than that, what we really need is that Indigenous worldviews and knowledge systems and Indigenous programming is being funded. And I think that this is something that is starting to happen, but certainly has not been the case for many of the programs that were part of this work, and that's something that they continue to advocate for. Lastly, these programs really demonstrate how traditional teachings and guidance from holistic Indigenous perspectives are making a difference. And so moving beyond what we historically thought FASD prevention could look like to Indigenous wellness models. The last thing that was included in the booklet, I think that this is so important, is we asked every author of this booklet created a reflection question, something that they wish they thought would be really helpful in thinking through in either developing or expanding an FASD prevention program. So how does our program support women, children, and families? How does our program integrate ancestors, elders, knowledge keepers, culture, and language? Have we followed the proper community protocols in all of our interactions? Have we created a safe and welcoming space for women? And certainly that is not a question that we can necessarily answer as program providers, but that we can answer, or that we hope that women who are accessing services can answer. And so all of this is included in what it means to revitalize culture and healing, that we think beyond the traditional model of FASD prevention, that we address stigma, that we highlight strengths of individuals, of families, of communities, of programs, and that we make sure that we are reaching extended networks and elders and knowledge keepers in all of the work that we're doing on prevention or wellness using whatever language feels best. So I'm so appreciative of the time and the space that you've given. I see that there were a number of things in the chat. Anna, thank you so much for putting the booklet in the chat. That is great. And again, I'm so sorry. Normally this is done in collaboration with one of the amazing Indigenous women and partners in creating this booklet, but that just wasn't a possibility for today.
Thank you so much, Lindsay. This was like a really inspiring presentation.